Welcome to Pharmacotherapeutics for Advanced Practice Nursing Across the Lifespan. In this video, we will cover Chapter 49, Drugs for Thyroid Disorders. We will cover a little bit about the thyroid physiology and pathophysiology, then the drugs used to treat disorders. The main drug to treat hypothyroidism is levothyroxine, and the main drugs to treat hyperthyroidism are methimazole and propylthiouracil. Synthroid, available generically as levothyroxine, is synthetic thyroid hormone. Tirosint is a capsule that contains liquid levothyroxine, and it's touted as being more absorbable. Thyroid hormone presents an issue with absorption. The dose is in micrograms, so it's very small, and if the entire dose is not absorbed, the levels may be off. The dose should be taken 30 minutes to 1 hour before food, and absorption can be affected by low stomach acid levels, as seen with calcium antacids and acid-reducing agents as used in GERD. Farmer thyroid comes from pork thyroid and has both T3 and T4. Liothyronine, or T3, may be preferred to T4 during radioisotope scanning procedures, since induction of hypothyroidism in those cases is more abrupt and can be of shorter duration. It may also be preferred when impairment of peripheral conversion of T4 to T3 is suspected. We will also touch on radioactive iodine. This slide shows the anatomy of the thyroid gland. It surrounds the trachea. When overstimulated, it grows in size, sometimes producing a goiter. Sometimes the enlarged thyroid is not huge, and patients and clinicians do not even notice it. One question to ask your patients is, do your necklaces seem tighter around your neck? As the thyroid enlarges, the necklace seems smaller. The thyroid hormones are known as T3 and T4. T3 is triiodothyronine, and T4 is thyroxine. T3 is the more potent hormone. T4 is more prevalent and is converted into T3. The drug Synthroid, or levothyroxine, is T4, a synthetic thyroxine, which is equal to the natural hormone T4. There are some combinations of T3 and T4, such as lyotrixothyronol, and they may have been withdrawn from the market by the FDA. Synthesis of thyroid hormones occurs in the thyroid gland. Iodine is taken up by the thyroid and attaches to the tyrosine thyroglobulin complex. The complex accepts either 1 or 2 iodine, creating either monoiodotyrosine or diiodotyrosine. The monoiodotyrosine and diiodotyrosine are then coupled into either T3 or T4. Few words about iodine. Iodine is needed for incorporation into the hormone. We start off with iodine, which, as said before, is needed to make the hormones. It is incorporated into the tyrosine thyroglobulin complex. If there is insufficient iodine in the diet, there will be a deficiency of T3 and T4. We get iodine from dairy, some fish, and iodized table salt. Some patients on low sodium diets may not use table salt. Most processed foods, such as canned soups, do not contain iodized salt. And many of the specialty salts, like sea salt, kosher salt, or Himalayan salt, usually do not contain iodine. So people can rely on getting their iodine from foods, and the foods that contain iodine are fish, cod, tuna, shrimp, and dairy products. But what if your patient is a vegan on a low sodium diet and is allergic to shellfish? These patients may present with iodine deficiency. Some multivitamins do contain iodine. The Centrum multivitamins contain 80 micrograms of iodine, which is 53% of the RDA, and Centrum Silver has 100 micrograms, or 67% of the RDA. So multivitamin supplements may be a good suggestion for these patients. There are also foods that are called goitrogens, and they contain thiocyanates, flavonoids, and goitrins, such as the cruciferous vegetables, Brussels sprouts, cabbage, cauliflower, and broccoli. Flavonoids are in red wine and green tea and are usually considered healthy, but they can be converted into goitrogens by gut bacteria. The goitrogens interfere with the production of thyroid hormones by blocking iodine uptake and by interfering with thyroid peroxidase, the enzyme that incorporates iodine into the hormone and reducing TSH. It's important to consider the fringe issues when challenged with patients suspected of hypothyroidism. Once made, the T3 and T4 get released into the periphery, where T4 is converted to T3. The T3 and T4 are highly protein bound, about 99.5%, so very little is free to exert its effect. And this protein binding leads to a very long half-life. Because of the long half-life, the time to steady state is extended to about 35 days. Therefore, you need to wait at least a month to evaluate therapy. The other thing with long half-lives is that when discontinuing therapy, such as when you're preparing for scans evaluating TSH after cancer, you need to wait a long time where the patient is hypothyroid, and that may cause some symptoms. Thyroid hormone has three actions: energy, growth, and cardiac actions. And the actions are mediated by T3. These actions are a result of the hormone interacting with DNA and RNA. So what does all of this mean? It means that every cell in the body needs thyroid hormone for proper function, for energy use, for promoting growth and development, and proper function of the heart. During times of deficiency, all of these are negatively affected. So what is the mechanism of T3? Well, it enters the cell nucleus and binds to receptors in the nucleus. These receptors bind specific DNA sequences, which lead to modulation of gene transcription. Gene transcription is where DNA is transcribed into a protein. These proteins go on to exert their effects, which are the effects of thyroid hormone. Thyroid hormone is regulated via a negative feedback system. The hypothalamus secretes TRH, or thyrotropin releasing hormone, which stimulates the anterior pituitary to secrete TSH, or thyroid stimulating hormone. The thyroid stimulating hormone causes the thyroid to make T3 and T4. The T3 and T4 report back to the pituitary. If there is sufficient, the production of TSH is reduced. If insufficient T3 and T4, TSH is still secreted and more thyroid hormone is made and secreted. When there is insufficient iodine, the levels of T3 and T4 are low, resulting in continued secretion of TSH, resulting in continued stimulation of the thyroid gland, which causes it to grow, forming a goiter in an attempt to make more hormone. This slide lists the actions of thyroid hormone, and there are a lot of actions. Remember, thyroid hormone affects every cell in the body. This slide goes over the pathway for secretion and the negative feedback mechanism of thyroid hormones. What tests are used to diagnose thyroid disorders? Testing TSH levels, serum T3 and T4 are the typical tests used. When TSH levels are high, it signals that the body is asking for more hormone, and the patient is hypothyroid. These tests are also used to monitor therapy to see if the T3 and T4 levels are sufficient in the treated patient. Let's look at hypothyroidism first. The types differ in severity. Mild deficiency is termed hypothyroidism. Severe deficiency is myxedema, and deficiency at birth is congenital hypothyroidism. If it's severe, we see cretinism. The clinical presentation is usually dry skin, loss of hair, and outside margins of the eyebrows, coldness, tiredness, hand and finger pain, numbness, constipation, weight gain, impaired libido, impaired fertility, and a low-pitched, hoarse voice may happen. Mentation may be slowed, and the face may be pale and expressionless. Speaking from experience, there may be weakness in the hands and arms, the hair falls out in clumps, and you feel as if you're inside a cloud and just can't think or concentrate. You can't come up with words or answers to questions. When treatment begins, you feel as though you are alive again. Causes of hypothyroidism include autoimmune disorders or Hashimoto's thyroiditis, iodine deficiency, and iatrogenic causes the medical system caused that mainly as a side effect of the treatment for overactive thyroid. Therapy is relatively simple: replacement, usually with levothyroxine or T4, which is converted to T3. The levothyroxine products on the market may differ in absorption, and that is how Tiracet is promoted. Remember, Tiracet is a liquid in a capsule, but the liquid in the capsule is levothyroxine, just like the tablets. Sometimes T3 is used, especially if it is suspected there is an issue with conversion enzymes. Treatment for hypothyroidism with supplemental hormone is usually lifelong. Because minor differences in bioavailability can make a difference, it is encouraged to stick with the same manufacturer of either the brand, Synthroid, or the same manufacturer of the generic. It is the responsibility of the pharmacist, as well as the prescriber and patient, to keep an eye on this. The patient must report to the clinician that their medication is now a different generic. Thyroid hormone should be taken first thing in the morning on an empty stomach, 30 to 60 minutes before food, to avoid a reduction in absorption. Thyroid hormone is better absorbed in an acid stomach, therefore acid reducers may reduce absorption. But once the patient is stabilized on both the acid reducer and levothyroxine, as long as there are no changes, levels should remain steady. There are issues with the pregnant female and hypothyroidism. Left untreated, Hypothyroidism during pregnancy can lead to developmental problems in the fetus or child. Issues such as permanent neurological deficits with reduced IQ and physical deformations can occur. Causes of hypothyroidism during pregnancy can include autoimmune disorders, use of drugs such as phenytoin or rifampin, which increase metabolism of thyroid hormone, or iron deficiency, as well as ablation of the thyroid as treatment for overactive disease. Cretinism is defined as a condition characterized by physical deformity and learning disabilities that is caused by congenital thyroid deficiency. Treatment is with hormone replacement. Hyperthyroidism is too much thyroid hormone produced. The clinical signs include nervousness, hyperactivity, heat sensitivity, weight loss, and sometimes exophthalmos. The forms of hyperthyroidism include Graves' disease, Plummer's disease, and thyrotoxicosis or thyroid storm. Graves' disease is the most common hyperactive thyroid disorder. It is where immunoglobulins bind thyroid receptors, causing increased production and release of thyroid hormone. Exophthalmos is a sign where the eyeballs protrude due to an immune-mediated infiltration of extraocular muscles and orbital fat by lymphocytes, macrophages, plasma cells, mast cells, and mucopolysaccharides, which cause the eyeballs to protrude. Treatment for thyroid eye diseases include Tepezza or teprotumumab, a biologic inhibitor of insulin-like growth factor that can be used to treat thyroid eye disease to increase the inflammation and bulging. Pronunciation of that is teprotumumab. Here is just a slide that shows exophthalmos. Treatment for Graves' disease is to reduce synthesis and secretion of thyroid hormone. This can be accomplished with surgical removal, destruction of thyroid tissue with radioactive iodine, or controlling synthesis with anti-thyroid drugs such as methimazole or propylthiouracil. Drug therapy is preferred in the younger patient. Adjunctive therapy includes beta blockers to help with the symptoms. Plummer disease, or toxic nodular goiter, is symptomatically like Graves' disease, except there is no exophthalmos because it's not an inflammatory condition. The thyroid is enlarged due to multiple nodules, which result in extra thyroid tissue, which produces too much hormone. Treatment includes surgical removal or destruction with radioactive iodine. Thyroid storm is an acute and life-threatening condition. It occurs when a patient with thyrotoxicosis undergoes trauma, stress, infection, where the thyroid is stimulated to produce additional hormone. Symptoms include high fever, tachycardia, and potentially unconsciousness. Treatment, in addition to supportive measures, includes methimazole or propylthiouracil to reduce synthesis, iodine to suppress hormone release, and a beta blocker to reduce the heart rate. Thyroid hormone replacement is usually with a synthetic form of thyroxine or T4. It should be taken on an empty stomach 30 to 60 minutes before food and is highly protein bound. Steady state takes about 5 weeks due to a long half-life. Missed doses are not a major concern because they will not cause any acute issues. Adjustments in dose are based on TSH, T4, and T3 measurements. We need to wait approximately 6 to 8 weeks before checking levels in a patient who just started treatment. The major adverse reactions due to excessive doses of thyroid hormone. Interactions include reduced absorption in the presence of reduced stomach acid, H2 receptor blockers, proton pump inhibitors, and also for drugs that will absorb or adsorb it in the GI tract, such as calcium, aluminum, iron, and magnesium, as well as sequestrants like cholestyramine. Some drugs will increase the metabolism of levothyroxine. These drugs include phenytoin, carbamazepine, rifampin, sertraline, and phenobarb. If a patient is stabilized on these drugs, adjust the levothyroxine dose to the appropriate TSH, T3, and T4 levels. Thyroid hormone will increase the metabolism of warfarin, so you need to increase monitoring when starting or stopping thyroid hormone. Thyroid hormone can also induce dysrhythmias due to increased responsiveness of cardiac tissue. Also, the doses of insulin and digoxin must be adjusted when converting a patient from a hypothyroid state to a euthyroid state because of the changes in metabolism. Because of the narrow therapeutic range and the low dose in micrograms and the differences in manufacture, it is recommended that the patient stay with the same manufacturer of their generic, or the prescriber indicates brand medically necessary on the prescription when it is filled at the pharmacy. This slide shows some additional drug interactions to be aware of. If you look closely, both lithium and iodine can both increase and decrease thyroid hormone secretion. Salicylates like aspirin can displace thyroid hormone from plasma protein binding sites, so that patients on Synthroid and maybe at a higher plasma level than takes an aspirin and Lasix, there will be more free thyroid hormone with the possibility of adverse side effects such as tachycardia, and the patient may not know why they now have tachycardia. Let's look at the drugs that suppress thyroid hormone. We're talking about methimazole and propylthiouracil. Propylthiouracil works to suppress thyroid hormone by inhibiting thyroid peroxidase, which will reduce the conversion of iodide to iodine, preventing incorporation into tyrosine. Without the building blocks, the hormone is not produced. It also inhibits the peroxidase in the periphery, preventing conversion of T4 to T3. It takes time to see the effect because of the long half-life of the hormone already on board. And remember, there's too much in hyperthyroidism. So that's why we're treating with the propylthiouracil. So it takes about 3 to 12 weeks to see a patient reach the euthyroid state. Doses are adjusted to the T3, T4, and TSH to normal levels. The drug is well absorbed and is bound to plasma proteins. Propylthiouracil is hepatotoxic and is not recommended in patients with liver injury or in pediatrics. Methimazole also blocks the production of thyroid hormone, but does not affect the circulating T3 and T4. So, if you overshoot the dose, synthetic T4 can be given without concern of interference. This block replace method is employed to help maintain the euthyroid state. Methimazole has a narrow therapeutic index and can cause hypothyroidism, hepatotoxicity, and agranulocytosis. There are differences in the two drugs where pregnancy is concerned. Propylthiouracil can cross the placenta and cause fetal cretinism and goiter. Methimazole can cause physical deformities in the fetus. If an anti-thyroid drug is necessary during pregnancy, propylthiouracil is preferred in the first trimester, and methimazole is preferred in the second and third trimesters. The drug crosses into breast milk. It is suggested that a patient does not breastfeed during therapy. Along with causing hypothyroidism due to its efficacy, the drugs can also cause hepatotoxicity and agranulocytosis. Radioactive iodine is used to destroy thyroid tissue. It is taken up into the thyroid preferentially, and while there, emits destructive beta rays which destroy the thyroid cells, so they no longer function to synthesize hormone. More than one dose may be needed to achieve effective results. Often, too much thyroid tissue is destroyed, and the patient will need supplemental exogenous hormone lifelong. There are precautions after dosing with radioactive iodine. Within days, the radioactive iodine passes out of the body into the urine and saliva. The time it takes depends on the dose and the patient's age. Young people get rid of radioactive iodine faster than older adults, but you do need to be concerned with what's passing out in the urine and in the saliva. Most people don't feel different after treatment, but some will experience nausea. Patients must avoid exposing other people to the radioactivity, so they should avoid close contact, kissing, sex, and sharing cups, dishes, or utensils. Other recommendations include flushing the toilet twice each time it's used, washing hands well with soap and lots of water every time you use the toilet, using separate towels, washcloths, and sheets, doing laundry in separate loads, use separate trash bags for personal items like paper cups and paper plates and medical waste such as bandages. After 80 days, the trash bag can be thrown out with the other trash, and the time is based on the radioactive decay of iodine. It is suggested that patients that have taken radioactive iodine do not cook for other people. If they do cook, they should use plastic gloves and throw them away in that special trash bag that they're using. Dishes should be washed in a dishwasher or by hand. If disposable dishes are used, they must be again thrown away in that special trash bag and then discarded. Radioactive iodine dose is based on thyroid size, rate of iodine uptake, and the amount of radiation needed. Dosage units are in millicuries. The radioactive iodine is obtained from specialized nuclear pharmacies. Those closest to us are in Sharon Hill in Bethlehem, Pennsylvania, and also in Laurel, Delaware. Other drugs used in treatment of thyroid disorders include concentrated iodine solution or Lugol's solution. It contains a lot of iodine to suppress formation and release of thyroid hormones. It is used prior to thyroid surgery to help prevent storm and to treat thyroid toxic crisis. It is dosed as drops, which can be added to solutions to mask the bitter taste.